All right, it looks like we've got a pretty steady number, so I will go ahead and get started. Welcome to our Chapter 1 and 2 Provider Rules Town Hall. We're so glad you all are joining us this morning. We'll just get started with a couple of housekeeping items. And before I do that, we always like to start our meetings with our BHA values. This is something that we ground ourselves in each day that we are engaged in this work at the BHA of writing these rules and engaging with all of you. And those values are truth, equity, collaboration, community-informed practice, and generational impact. And in engaging with you today, we hope that we can center each of these as we discuss the rules and create a system that works for all Coloradans. So just a couple of housekeeping items. As you can see, this session is being recorded and we will post that to the BHA website. Our staff has access to the chat and the transcript so that we can ensure that all of the comments that are made today are captured in our rulemaking process as we take in your input. We are happy to have you share whatever you're comfortable with in this venue. And the ways that you can share both today and moving forward are through the chat, raising your virtual hand today when we pause for questions, our email address, which is here and we'll be sure to be dropping in the chat throughout our meeting today. We have a Google form and a survey response that's up on our website, which we'll also put into the chat where you can fill out a form to provide us with feedback on specific rule chapters and other questions and comments you may have. And we really do encourage you to reach out through those means if we're not able to get to your question or feedback today during our meeting, though we hope we will be able to get to everything. We have American Sign Language interpreters here today as well. So there are 2 interpreters that will alternate throughout the session. If you are needing interpretation or wanting to use that, you can open your participants list and find our 2 interpreters, Adrian and Megan, and pin them. And if you have any questions, feel free to direct chat me in the Zoom chat and we can help you if you're having any issues with that interpretation. Today's town hall, we are going to be providing information about chapters 1 and 2. This session is designed to be a little bit more content heavy than some of the other upcoming events that we have. So if you were able to join us last week at our kickoff, we have a really extensive calendar for the next 2 months through May and June of both in-person and virtual events that will be taking place. Many of those are designed to be really question and answer listening sessions to gather feedback from the variety of groups that we're seeking to engage with around the rulemaking process. This one's a little bit more content heavy, really diving into some of the specifics of chapters 1 and 2 and providing you with some of the critical information, changes, and framework so that you have that understanding. We do want to definitely include questions and comments as part of today's session too. So we will be pausing at different points throughout to allow for questions and comments, and feel free to at any point be entering your questions or comments into the chat. For those that we can respond to via chat, we will be doing so throughout the session. And we will visit those chats also during our pauses for questions. And I'll pass, before we pass it over to Victoria, we did not do introductions. So I didn't even introduce myself. Sorry about that. My name is Erica Gannett, and I am a safety net licensing manager here at the BHA, part of the team that is working diligently on this rule rewrite process. And I will pass it around to each of my team members to introduce themselves, and then Victoria will dive straight into an update. So I'll start by passing it to Tom.
Thanks very much, Erica. Good morning, everyone. Tom Miller, he, him, his pronouns. I'm the Division Director of the Quality and Standards Division. Thank you for joining this morning, Victoria.
Good morning, everyone. My name is Victoria Lasky, Associate Director of the Safety Net Unit at the Behavioral Health Administration, and my pronouns are she, her. I will pass it to Mariana.
Thank you, Victoria, and good morning, everybody. My name is Mariana Sears. My pronouns are she, her, and I will be presenting a little bit of information today around Chapter 1, and then at the very, very end of Chapter 2, so kind of bookends of our presentation today. And I am one of the Safety Net licensing managers. I will go ahead and hand it over to Mel.
Good morning, everybody. So glad you're here. My name is Mel Tyler, she, her pronouns. I am also a Safety Net licensing manager, and I will be talking to you today about 2.6.1, 2.14, and 2.15, and I will hand it over to Jenna.
Morning, everyone. My name is Jenna Kapp, she, her pronouns, and I'm also a Safety Net licensing manager, and I will be presenting on 2.12 and 2.13, and then I'm going to hand it over to Olivia.
Good morning, everyone. Thanks for being here. Olivia Zern, she, her pronouns, also Safety Net licensing manager. I'm just sharing slides today, so you won't really be hearing from me. Back to Victoria.
Thank you very much. So we'll get started with a pretty brief update or overview regarding the Behavioral Health Entity or BHE license. Chapter 1 is our definitions chapter, and then Chapter 2 is the base requirements for a behavioral health entity that is licensed by the BHA. So just for a little bit of historical context, this behavioral health entity license goes back to some legislation from 2019, House Bill 19-1237. Previously, I say previously, but really it's currently up until these rules are promulgated. Behavioral health service providers have been required to hold licenses from CDPHE, the Department of Public Health and Environment, also the Department of Human Services. There are differing requirements for mental health versus substance use disorder. And this has created a lot of different oversight burden for providers. And so we had this phased approach to rolling out this licensing category, the behavioral health entity license, that combines mental health services and substance use disorder services into a single licensing category and provides similar oversight to facilities that provide physical health. So that was the intent, to increase consumer protection for those receiving behavioral health services. So we are currently in this blue square, phase 1 of the BHE, where mental health providers have been required to obtain the BHE license from CDPHE by July 1st of 2022. Once these rules are effective, we will be moving into phase 2 of the BHE license, which is all behavioral health entities, including substance use disorder providers, must obtain the BHE license in place of their current SUD license through the BHA. Authority transfers to the BHA January 1st of 2024. Please note this is a recent change due to past legislation that passed a couple of weeks ago that amended this timeline from July 1st of 2023 to January 1st of 2024. By January of 2025, it's required that all BHE licenses will be through the BHA, and all those that require a BHE license will be holding that license. So the structure of the BHE license, and I've got a visual aid in the next slide, is that it is a base license with a number of endorsements based on the services provided or populations served. So each provider must have at least one endorsement. That BHE license does not contain any kind of service-specific requirements, really just that basic license for operation, for the ability to add those endorsements. So those are added to the license. CDPHE created this structure and has been calling it a cafeteria style license. And so we are moving forward with that similar structure with some additional endorsements as well. So specific chapters of rule contain requirements for each of those different endorsements. And some endorsements, I think all endorsements contain sub-endorsements. For example, residential services endorsement would include various American Society of Addiction Medicine or ASAM levels of care as sub-endorsements. In the provider providing, for example, a level 3.5 of ASAM would have that specific sub-endorsement on their license. Next slide. So this is that visual aid that we have as far as the BHA base license being the foundation, and then adding the endorsements that are separated out into these service type endorsements, which includes outpatient and high intensity outpatient, residential, emergency and crisis, and recovery supports. Population specific endorsements, which include services for children and family, gender responsive treatment, criminal justice services for those involved in the criminal justice system, and involuntary or emergency commitment services for a substance use disorder. We also have these endorsements that are applicable only to comprehensive community behavioral health safety net providers. You'll be receiving more information about it if you're not familiar with that. I'm sure a number of you are, but if you're not familiar with that particular provider type, our next rules town hall, walking through chapters 3 and 4, will include more information about what comprehensive safety net providers are and the requirements they are needing to meet. One of those requirements is holding these 3 endorsements: outpatient competency restoration, outreach, education, and engagement, and care management. Next slide, please. All right, I'm going to hand it over to Mariana, who will be walking us through chapter 1.
Right, thank you for that, Victoria. Hello again, everyone. This is the beginning of my bookend presentation. So we're going to cover a little bit of a high-level overview of chapter 1, which is our authority and definitions chapter. The main sources of information that we utilized here include our BHA current rule volume, 2 CCR 502-1, as well as the Colorado Department of Public Health and Environment rule volume, 6 CCR 1011-1, and then also Colorado revised statutes for various definitions throughout this chapter. Next slide, please. So one of the things that we are bringing back for this stakeholdering process here is we want to make sure that every time we look at these chapters, we do take a minute to look at this from a person-centered summary. What does this chapter mean for the individual who is receiving services? So what we're going to do at the beginning of each of these presentations is for each chapter, there will be a brief person-centered summary that is written with the intended recipient as the individual who is receiving services to help them to better understand how our rules impact their behavioral health services received. So this particular chapter describes why the BHA is creating the rules in this entire rule volume. If a word has a specific meaning in the rule volume, it's going to be defined here. Knowing the specific meaning of the words can help you better understand the rules if a word could have more than one meaning. And so for the purpose of moving forward, please note that if a word has a specific meaning that's only applicable to one chapter in the rule volume, that word will be defined before that chapter, but will not appear in this chapter 1 definitions. Next slide. All right, so looking at definitions, there's a handful of main foundational elements we're trying to achieve with this chapter 1 of nothing but definitions. Really what we're trying to do is set a foundation for our updated chapters and licensing process. And we'll talk a little bit more about each of these bullet points in the next couple slides. And I apologize, I skipped the first bullet point there. You'll notice from a provider's perspective, some definitions might look very familiar and they've been carried over verbatim from one of the sources that we already referenced. Some might be slightly modified or moved in how they are presented or where they live in the rule volume, and some may be removed entirely. So please keep that in mind as you're looking at this chapter 1. Additionally, we're seeking alignment and incorporation of language and enhancing of person-centered services that is based in our very base chapter of definitions and what we're all about. So setting the foundation for the updated rule volume. There are a few terms that you will see looking at this chapter 1 that may be a bit different than what you see in our current 502 CCR -1. And so those are items like endorsements, telehealth services, in-person services, and identifying treatment type. So we're really utilizing this chapter to make sure that we provide the basis for updating our licensing structure. Future state, it will give us the ability to grow more easily and make sure this is more easily understood by all providers. This chapter 1 contains all definitions, like we said, that apply to more than one chapter. So this hopefully will end up with less searching of the rule volume and less section-specific definitions, reducing confusion and overlap or conflict with definitions across our rule volume. And one new thing that we pulled into this particular chapter is the incorporation of mental health diagnosing standards. You will notice that the DSM-5, or Diagnostic and Statistical Manual of Mental Disorders, has been incorporated by reference into this chapter. Next slide. All right, and so moving towards alignment and incorporation of language, you will notice that we have incorporated some language that currently exists in the health department's rule volume, Colorado Department of Public Health and Environment. A few of those existing terms that you will see moved over and part of our rule volume that has been updated, letter of intent, and qualified medication administration person, or QMAP. This is just a small sampling, but just giving an idea of some terms to look at. If it doesn't look familiar, these have pulled from a specific and existing resource. And then one other thing to keep in mind, wherever a statutory definition for a term already existed, we use that definition. So for example, child is statutorily defined as an individual under the age of 18. And so we kept that definition in these regulations and in this rule volume. Next slide. There we go. So this slide focuses on how we're trying to make sure to enhance person-centered services, even through setting of proper definitions and making sure our rule volume has the best foundation moving forward. There is a stronger focus on the person receiving services. You will see several definitions that are focused on responsive treatment services and things that are not present in our currently applicable rule volume. A couple examples of this include trauma-informed care, harm reduction, utilizing the SAMHSA definition of recovery, and inclusion of whole person health as a goal that we're striving to achieve. You'll also notice that this chapter sets up the foundation for treating of the individual and not just the diagnosis. We do have behavioral health defined in here as a combination of substance use and mental health. Again, really wanting to make sure that the providers recognize and are able to treat an individual who's receiving services and not just the diagnosis or symptoms that brought them to services. And also adding a care coordination, which will help to create that network for the individual to receive their individualized and needed care. Next slide. Okay, so this chapter is a little bit unique in the sense that we have a whole part that is devoted to personnel definitions. And this is intended to make one landing zone where any questions or concerns that a provider might have about who can provide a service or how a particular professional is defined lives in this place whenever possible. We made a lot of effort to align those definitions and to go across chapters to make sure that they are consistent. And if there were certain sections or parts that needed to be defined a little bit differently, that we tended towards using the standardized definition when possible and then having exceptions when necessary. So I draw your attention to this one particular example. Authorized practitioner is a definition that we have in the current chapter 1 proposed update. And this is a person who is A, authorized by law to prescribe treatment, medication, or medical devices, who B, holds a current unrestricted license to practice, and C, is acting within the scope of such authority. And this includes, but is not limited to, physician, psychiatrist, medical doctor, or doctor of osteopathy, licensed, a physician assistant who is licensed, or an advanced practice registered nurse who is licensed. And I skipped the parts there just so that I don't rattle those off incorrectly as I'm talking here. Next slide. So part of the reason that we're highlighting the APRN definition is this one's a little bit unique because we have APRNs are listed explicitly under authorized practitioner, but you'll also find an APRN as a standalone definition. This was done to support that standardization of Chapter 1 as the main landing spot for definitions to live. This allows the chapters to specifically reference an APRN when their scope of practice may not match authorized practitioner as we have it defined otherwise. So a couple examples of that would be Chapter 2, which is the base BHA license, and Chapter 15, which is our updated 2765 regulations. So, and then the definition of an APRN as a standalone definition is listed below for your reference. Next slide. We also provided some updates to make sure there was standardization and understanding of a lot of staff that are utilized for provision of services. And so we have a definition of candidates that was added. This is a person receiving clinical supervision, acting within their scope of practice, and seeking licensure through the Department of Regulatory Agencies, or DORA. It includes psychologist candidates, clinical social work candidates, marriage and family therapist candidates, licensed professional counselor candidates, and licensed addiction counselor candidates. We'll talk a little bit more about supervision here in a second. Let's see here. So clinical supervision. This means essentially that the person supervision that is received to meet the standard qualifications for supervision as defined by a practice board and standards in the Colorado Mental Health Practice Act. The delivery, frequency, and specific requirements may vary depending upon the credential and the respective skills of the two professionals involved. So it might look slightly different depending on who's providing the supervision and who is receiving the supervision, as well as the population or the individual that is being served. Supervision provided to personnel who are not seeking or not eligible for professional licensure, but otherwise are able to provide services, implies that the supervisor accepts oversight and responsibility for the services provided by this personnel. And again, we want to make sure that everything that we're putting forward supports DORA standards. And so this reflects back onto that particular supervisor and their individual mental health practice act. Next slide. And again, just going through, I'll start to fly a little bit more through these. We have a couple more that we added in for clarity, counselor and training, making sure that that's abundantly clear. Added addiction counseling focused personnel definitions, including CAS, certified addiction specialist, CAT, certified addiction technician, and LAC, licensed addiction counselor. This is something that kind of sporadically through the rule volume as it currently stands is referenced and defined multiple times. This way it can live in one place. And these definitions are based on the personnel certification or license that is issued by DORA. And again, main priority, we want to make sure that this aligns with the personnel's level and scope of practice per Part 8 of Article 245 of Title 12. We've added in a definition for intern. This is an individual or a professional who is definitely present in behavioral health services, but not one that we had explicitly listed in rule. These are personnel completing a clinical degree program of study, performing duties under the direct clinical supervision of degree corresponding licensed personnel. So again, we want to make sure there is some room to help with understanding who an intern is and what they are able to do. And we have changed licensed mental health professional definition to licensee to better match Colorado revised statutes. And this means a psychologist, social worker, clinical social worker, marriage and family therapist, LPC, or addiction counselor, licensed as defined in Title 12. Let's pause there. That was a lot of information on definitions. Anybody have thoughts, questions, concerns?
Mariana, this is Cindy Dodds. I have a question.
Yes,
So This is probably a minor detail, but when I look at the way, as you guys have brought in both ASAM and then the DSM, it talks about no later additions or amendments are incorporated. I know that ASAM is under review and there will be a new version that comes out, I think, relatively soon, sort of as things go. Does that mean that then these rules would have to be revised to be able to incorporate the most recent version, a newer version of the ASAM?
Yes, Cindy, thank you for that question. It does. So when we are incorporating by reference, we have to be able to identify one specific version of whatever the tool or the reference is. And then anytime that we want to bring in a more recent version, we do have to go back through the rule process. This particular one is a bit of a pain point because we were really hoping that we could align the updated ASAM 4 with this whole process. And unfortunately, just the timeline is off by just a few months. So what we are looking at and proactively preparing for is moving forward with the 3rd edition of ASAM, but at the same time, as soon as we have some downtime with this current rule volume, starting to proactively work on what do our updates need to be to come into alignment with ASAM 4th edition as soon as we can possibly do it, and making that part of our regular ongoing rule process.
Thank you.
Absolutely. Any other thoughts or questions? I'm seeing none. All right, so thank you for your patience as I went through that somewhat dry material. I will go ahead and hand it over to Victoria for chapter 2.
Thanks, Mariana. So chapter 2 is our chapter on general behavioral health entity licensing standards. Our main sources for this chapter 2 are the BHA current rule volume, the CDPHE rule volume governing behavioral health entities, and also our BHA grievance and critical incident policy manuals. As Mariana introduced, we have a person-centered summary for each of these chapters. The one for chapter 2 is seen here. So behavioral health providers must follow rules in order to ensure that you're receiving high quality services. And in order to receive that BHE license, a provider must follow these rules. And this includes rules about your rights as a person receiving services, training for staff that work with you, how the provider will work with you to identify your needs, building safety, requirements for residential settings to ensure your health and comfort, how a provider applies for a license, and what happens if a provider is in violation of the rules. Slide. All right, I wanted to make sure that we had a specific slide on this because I know this is a hot topic and usually generates some questions. We are working on getting written guidance posted to the website on this, but I just wanted to cover the basics here before we dive into chapter 2, and that is regarding license transitions. So I think probably a number of you on the call are already at an agency that is licensed through CDPHE as a behavioral health entity. Those types of providers will transfer to the BHA upon expiration of their annual license. So there will be a transition year from January 2024 to January 2025, where all annual licenses will come up for renewal. And then at that point, the provider would apply to the BHA to renew. So this is not a situation where we say rules are effective January 1st. That does not mean that you need to have your license through the BHA by January 1st. I just want to make sure that's clear because I know that can be a point of anxiety for licensed entities. CDPHE will maintain its current BHE regulations through this transition year. So the BHEs will be held to those current licensing standards until the time of transfer to the BHA. And as I mentioned, we'll have this written guidance in the form of a frequently asked questions or FAQ document on our webpage. The other type of currently licensed entities that are probably interested in their transition timeframe is agencies currently holding a substance use disorder license or a mental health designation through the BHA. So the BHA, this is going to be a similar process as those licensed by CDPHE. The BHA will maintain its current regulations for the SUD license and the mental health designation through the transition year. And at the time that that license or designation is up for renewal, the agency will be applying for their BHE license and then subject to these new regulations that we are presenting on today. All right, and with that, diving into the content of Chapter 2, Authority and Applicability. So this is the section that outlines really that license requirement, and up to the point where it will be unlawful to operate a behavioral health entity without a license beginning January 1st of 2025. So again, that's at the end of a transition year where currently licensed entities will be transitioning their license from either CDPHE or from a different license type to a BHE through the BHA. And I know that's a lot of acronyms I'm throwing around. I also wanted to highlight that this section includes delayed enforcement. So this was a piece that came about as we were talking about some shifting timelines. So the BHA what we have in current proposed regulations is that the BHA will enforce and take adverse action against BHEs for rule violations that impact health, safety, and welfare between January 1st of 2024, which is when the rules are effective, and March 31st of 2024. And full compliance of all rules would be required by April 1st of 2024, or the time of application if the application date is after April 1st. So just by virtue of the fact that, providers may have applied for their license at any given point in the year, this allows providers that happens to fall in that first quarter to have some additional time to come into compliance with the rules. I also want to highlight that initially when we discussed this delayed enforcement, it was for an October 1st effective date. So that was a full 6 months of delayed enforcement. We are open to feedback about if it makes sense to move this to a 6-month time frame. So instead of April, that would be delayed enforcement until July. So I just wanted to mention that we do have this April date in the rules, but this is something we specifically would like some feedback on as far as if it makes sense to extend that 6 months out to a July delayed enforcement date. All right, and I'm going to pause here. I saw there was a little bit of activity in the and I see a hand raised. So it looks like we're generating some questions. I saw there was one about, will the slides be available? Yes, we will make those slides available. Let's see. Oh, and I see, Tom, do you want to address Sarah's question? I hadn't had a chance to read through that yet.
Hopefully I did in the chat. So Sarah, let me know if you don't find that answer sufficient. Basically, what I'm driving at is that if it seems to be getting close to that January 1st timeline and the application, the initial application is not yet approved, I think that the BHA and CDPHE should meet with you and talk about who will complete what steps. So we'll try to make that an individualized process.
I also see a question from Nancy. Are there specific sections of the rule that you define as health, safety, and welfare? What are the types of rules that will not be enforced? Tom, would you be able to help out with that one?
Sure thing. And Nancy, I'm happy to talk with you at length if we don't get down to the specifics in this particular meeting. I would say that first, there's no specific section of rule that we call health, safety, welfare rules. It's going to depend on provider type and which particular endorsements the provider has. So within that, if we are investigating based on a complaint or a grievance, or we are there on a renewal, either way that we engage, if we determine that there are deficient practice, and those deficient practices intersect a specific section of rule, and we determine that has some kind of potential for immediate harm to the person in question, we would call that a health, safety, welfare. If conversely, we are there on a complaint or they're doing a renewal and we find deficient practice, but that doesn't have any corresponding immediate health, safety, welfare issues, we're talking about with this delayed enforcement that we won't take an adverse action against the facility's license. Rather, we would cite the deficiency and work with the facility to help bring them, or rather bring them back into compliance. I hope that answers, and if not, happy to chat with you offline if you like.
Thank you for that, Tom. Edie, I see your hand is raised.
Sorry, it took me a second to get myself squared away here. Edie Sun with the Colorado Behavioral Healthcare Council. And I've raised this question in other settings, but because we've got some different people here today, I want to raise it here as well. In House Bill 1236 that just passed, the BHA implementation update bill, there the language that was added about the new timeline seems to have what we believe was probably a typo, that in terms of the date for the transition from CDPHE to BHA license oversight, so that it looks like there is the potential for both entities to oversee licenses for a period of time. And with our understanding from your policy team, and I think we've heard that from the rules folks as well, that you got a legal opinion that the legislative intent of 1236 makes it clear that BHA oversight trumps. But I want to confirm that and see when that written legal opinion will be available, because we are quite nervous about our folks potentially being subject to licensure oversight by two different agencies for a period of time. Thank you.
Edie, I did talk a little bit with Ryan about this, and maybe I didn't do a good job getting the specifics from you to inform my conversation with him. But do you have any language that you could just send me so I know exactly what the issue is?
Yeah.
And thank you for that. And then secondly, the legal opinion you reference, when we get informal opinions, we don't share those with anyone outside the BHA. So and maybe you weren't implying that you were hoping to see what that language was. And maybe you only meant that, hey, you get it so that the BHA can be informed about that. But I just didn't want to have any misunderstanding in that regard.
So actually, I was asking to see that language, and I had not gotten the information previously that informal legal opinions were not available to external audiences. Perhaps there could be a formal legal opinion. I mean, as I said, it's very important not only for CBHC members, but for any other provider that language is that we have absolute clarity that will only be overseen by one agency at a time. And of course, everything that's been laid out right here is that, yes, there is a date certain at which the licensure for each entity switches over from CDPHE to BHA. And that's the understanding under which all of our folks have been operating. But because of that issue in 1236 that happened literally at the 59th minute of the 11th hour of the legislative session, it created considerable fuzziness about that. So we really do need absolute clarity in writing from somebody about that.
Sure, and I didn't mean to imply that we won't have absolute clarity, but conversations with our lawyers in that informal opinion is privileged, so we don't send that out in the same way. If you talk with your lawyer, you don't give it to us. A formal legal opinion is actually from the Attorney General himself in this particular case. So we typically don't ask for true formal legal opinions. It's extensive in terms of the review, the time that it takes to get them, and also the cost to state government. So I would say we don't intend to do that unless we don't have clarity. And again, I don't anticipate that we won't have absolute clarity and that the BHA won't be able to inform you and other providers about that.
All right, thank you. Just so long as we get something in writing pretty darn soon. I hate to be just a pain in the neck about this, but this is an issue of some concern for our folks. So thank you very much. And I'll shoot the problematic language from the bill to you.
Thanks.
And we'll take one more question before we continue on so we can get through our content. I see Cindy's got her hand raised.
Thank you. So I have a question in terms of transition as well. So thinking about that timeline for an organization that might currently be licensed is going to then transition their license after that January 1 time. You know, we've talked previously about for those of us with electronic health records, the work that has to happen with EMR programming can be a bit. Has there been any discussion? I'm thinking that there's a couple of organizations, Summit Stone is one of them. We're in the process of transitioning actually our whole EMR, and so doing all of that EMR build. Has there been any discussion with CDPHE where there might be able to be some waivers to have some pieces of the new rule that you almost might be in compliance with early to support your EMR or programming, and or maybe need some extension past that April 1 if you're a later organization coming in programming? So wondering about waivers or exceptions either with CDPHE or the BHA in terms of some specific rules and how that might connect to an EMR. I hope I asked that well. I feel like I did not state that very clearly.
So I'll repeat back just to make sure I'm following, Cindy. So the question is, as organizations are working on transitioning their internal processes, including electronic records, to be compliant with new requirements through the BHA, what is the process for if you're currently under CDPHE and you're working internally to get those things in order, what does it look like for CDPHE to be enforcing their regulations where they may conflict? Am I understanding that correctly?
Yes, so where they conflict, where there's currently, I don't know, I'm going to talk about some of the stuff in terms of assessment or treatment planning, where in the new rule, there's different timelines, some different pieces, and trying to get that lined up. Hopefully, we're able to do that in a way that says it won't come online until this date. But I just think about some of the builds and some of the work that it's happening, that it may actually be really advantageous if you could either implement the new rule earlier, a month or two earlier than expected, or need some transition time for somebody that maybe their license is coming up April 1 or May 1 of 2024. So yes, on either side.
I can speak a little bit to the BHA side of this, and then maybe Tom, if you've had any additional understanding or communication with CDPHE from their side. I think from ours, this is where some of those delayed enforcement pieces can be really helpful, where if, for example, you're coming over and your assessment is more in line with CDPHE's regulations, and that's something that, as Tom emphasized earlier, is not an apparent issue as far as health, safety, welfare. That's something that we would allow that delayed enforcement to take effect, where we would not be taking any adverse actions if things are just arranged a little bit differently in an EMR. So I think that piece from our side, and then Tom, if you have any additional thoughts about the CDPHE piece.
Yeah, Victoria, you took the easy part of the question there. It's a little bit harder for us to speak to CDPHE's approach on this. And the way I interpreted the question, Cindy, was if you're building your policies or your process to be in compliance with the draft rules that, let's say, are ratified as written for the BHA, does that mean that you may be operating out of compliance for the rules for the license that CDPHE currently issues to you? So prior to the transfer is another way to say that. Is there any way that CDPHE could not enforce those particular rules or issue a waiver? And so we can't necessarily speak to CDPHE's authority or how it would handle that specific situation. The official answer would be you can always apply for a regulatory waiver with CDPHE for them not to enforce that. I think the unofficial response here is let's get together with CDPHE and have a conversation about exactly what that situation is, and if there's anything the two agencies can do with you to make sure that that's not a burdensome situation. So at this particular point, that's probably the best that I could offer, again, because I don't have the authority to control CDPHE's process. What do you think, Cindy?
Thank you. I appreciate that.
Sure.
All right, continuing on with our review of Chapter 2, a couple of definitions added to this Chapter 2 include this behavioral health entity definition, which comes from statute. I will note that there are a number of statutory changes that are hot off the press that we are still working on getting those integrated into the current rule language. Most of it was posted mid-April, I believe. So we are still working on catching up with some of those legislative pieces that have recently passed. But I did include here that there was one change to the behavioral health entity statutory definition, and that is removing that behavioral health entities may not include residential childcare facilities or RCCFs. So those facilities may seek a behavioral health entity license per this statutory change. So this is, and thanks for that detail, Mariana. So a facility or provider organization engaged in providing community-based health services, and a couple of exclusions still hold here. So detention and commitment facilities operated by DYS within the Department of Human Services, or services provided by a licensed or certified mental health care provider under the Provider's Individual Professional Practice Act on the provider's own premises. We also added this definition, and this isn't new. This was presented at State Board in March. So this is probably familiar to a number of you already. This provider organization definition, meaning a corporation, partnership, LLC, business trust, association, or other organized group of persons in the business of behavioral healthcare delivery that includes 10 or more full-time equivalent, fully licensed or certified mental health care providers under the Providers Professional Practice Act. The exception to this 10 is any size providing 24-hour, so overnight services, overnight community-based services. So an important piece here is the community-based services. I want to be very clear that this is not inclusive of hospitals. So community-based is statutorily defined as outside of a hospital. So this would be a residential treatment program that maybe only has 7 or 8 full-time equivalent clinicians. They would still fall under this provider organization. Next slide, please. So this is the license requirement section, part 2.3. So this is all statutorily established that those formerly licensed by CDPHE as a BHE must have the, again, alphabet soup here, the BHA, BHE. Formerly approved or designated by the BHA to provide substance use disorder or mental health treatment. So that's talking about those SUD licenses that I mentioned earlier. And then entities not formally subject to licensure that meet the definition of a BHE. The biggest category here is private pay facilities. So specifically with the SUD license, the requirement for the SUD license has historically been that the program is receiving public funds. The BHE license is agnostic to payer. So this means that if you are providing these services and you meet this definition, that you would be required to have the BHE license, even if not receiving public funds. So I just wanted to highlight that piece in case there was not awareness of that. So moving into general license requirements. Oh, and I see a raised hand. We'll pause for a question from Barbara.
Actually, my question is about 2.4. So if you want to go,
Very good. So I'll cover the slide and then go over to you. You were ready to go.
Yep.
Love that. So general licensing requirements, BHEs must have at least one level of service endorsement. If the BHE, I did it myself, has not provided a service for which it is endorsed for 1 year, the endorsement will be reviewed for removal. This is similar to current practice with our SUD license. Endorsement standards are described in the following chapters. An important thing to note is the behavioral health entity license is an entity-wide license, and it is a facility license. So this is not for individual clinicians or practitioners, and the endorsements are location specific. And this also includes a list of what is considered outpatient versus overnight endorsements, because that particular distinction comes into play in a few other parts in chapter 2. All right, now I'll go to Barbara.
Okay, so in 2.2.3, actually there's probably a letter in there, but yes, A3. It says the following endorsements are considered outpatient service endorsements. So does that mean that a separate endorsement is not needed to provide the services listed there, such as mobile crisis services?
So the endorsement is required to provide those services. This list is really just defining, there are other parts and rules specifically I'm thinking of the fee schedule and records retention of what an outpatient service endorsement fee is versus a residential or overnight. So this is really just listing out, these are the specific endorsements that are considered outpatient, that endorsement, for example, mobile crisis would be required for a BHE to provide that. Okay, so
explain that further, because I'm not understanding then what the purpose of that list is. If mobile crisis is considered an outpatient service, so I get my outpatient service endorsement, and I still need a mobile crisis service endorsement.
Yes, so the distinction here is this category in 3 is really just used as a point of convenience to say these are considered the kind of big picture outpatient service endorsements. Outpatient as far as the specific service, for example, outpatient therapy or an equivalent of ASAM 1 is specific to chapter, I'm going to get myself in trouble here. I believe it's chapter 7 now. So that's a specific endorsement itself where you see 3A and 3B, that is specific to a chapter. This list is really for convenience because later on we say, if you want to add or if you you're looking at record retention for an outpatient services, we say you have to retain records for this long for outpatient services. And this is what we mean when we say outpatient services. So it's really just kind of a convenience mechanism to categorize them all in 2 buckets.
Okay, so child and family services is not in that list under 3. Does that mean that child and family services is not considered outpatient services?
That's a great question. So that one we consider a population specific endorsement and could be across the continuum. So it could be residential or outpatient for child specific.
So if there, because I would think that what applies to outpatient services also applies to outpatient services if the person we serve is a child.
Correct. So it would be if you are serving children on an outpatient basis, it would be the endorsement for outpatient services and then the population specific endorsement for children.
Okay.
Does that make a little more sense?
Well, it makes, I'll say, I understand now what you're saying, and I'll just get all the relevant endorsements to us. I guess I would point out that I'm assuming that if I'm confused, there might be others who are confused as well.
I think that's a point well taken, Barbara. And we can think through if maybe there's a way to reword this to make it clear what these lists are and why they exist. I think that's kind of what I'm getting from your question. So I really appreciate you bringing that up.
Because you know that I have not been living with these as long as you have, or as much as you have, but probably I'm on the 2nd tier.
Right, and I think I need to be very sensitive to that. I definitely live in this world. So I'm very open to feedback of, my goodness, that does not make sense to me. Like, how can we clear this up? So thank you for bringing that up. That's appreciated.
Okay, I'm gonna put my hand down now, and I do have questions in 2.5 when you get there.
All right.
Thank you.
Thanks, Barbara. Did we have, I thought I saw another hand up at some points. Or maybe I imagined it. Oh, Bonnie, did you have a question?
I did. Thanks, Victoria. This is probably a silly question, but that bullet point that says BHE is entity-wide license and endorsements are location specific. So I think in terms of the mental health transitional living homes, we have 3 that will be state run. Does that mean we'll get 1 BHE license for those 3 homes and then endorsements for each of those locations?
Whoops. That's a good question, Bonnie. We might want to, that's a very specific, unique scenario. I think let's chat about that in one of our upcoming meetings, and we can dial down to what exactly the expectation would be there. Because I think that's going to be a pretty unique one.
Okay, that'd be great. And I also think in terms of some of the providers who are responding to the RFA, they may have multiple locations that provide various services, but they are an organization and they may get endorsements specifically for the MHTL home. So maybe we can just chat about those 2 things offline at some point.
Absolutely.
Thank you.
Thanks, Bonnie. All right. 2.5. So this is the governance section, and this is specific to requirements of the governing body. I know this, if you've been around for a bit, are probably familiar with this governing body piece. I think we've received a lot of feedback about these expectations for the governing body. And one specific piece that I wanted to address here is that we received feedback of, you use this term governing body. Is that a board of directors? My type of business formation does not require a board of directors. Does that mean I have to create one? And so I just wanted to draw attention to this governing body definition, meaning the board of trustees, directors, or other governing body in whom the ultimate authority for the conduct of the agency is vested. So in the case of an organization that is not required to have a board of directors, we read this other governing body as fairly broad and could be inclusive of, for example, an executive leadership team, if that's the appropriate type of oversight for that organization. So I just wanted to make sure to address that, because I know that's been a topic of concern, of discussion historically. And this section includes policies and procedures, didn't list them all out, but including such things as clinical and administrative oversight, grievances, personnel, individual records, use of individual feedback in governing body decisions, building safety and security, and emergency preparedness. All right. Yeah, I was waiting for your hand, Barbara. What do you got?
Okay, so I'm looking at 2.5C, in which it says that it allows the governing body, if it has a board of directors, to delegate to management responsibilities to an executive management team, and so on. And then number 10, I'm just scrolling, allows it to, one of the things that can be delegated is developing, implementing, and annually reviewing policies in accordance with part 2.5D. So where that gets confusing to me is that 2.5C allows delegation to the governing body of policies and procedures, from the governing body to the executives of policies and procedures. But D specifically says the governing body shall be responsible for ensuring the development and implementation of the policies and procedures. In D, it is not allowing delegation to the executive or the executive team. So that to me seems to be a conflict, a contradiction there, that one is allowing it and then the other isn't. And also there in D, I know I've mentioned this before, I still find that confusing in D, where it says about first annual review of changes to the policies and procedures, and then in the last sentence about review every 3 years. Number one, changes shouldn't be just reviewed annually. Changes should be reviewed when they happen. And it should be by the executive team that's carrying them out. When they happen, they should be reviewed and approved right then and there. It shouldn't happen annually. So it's confusing there about that annual and the 3 years. And again, it's still going back to this requirement that the governing body be reviewing them. And it's just not something that should be the responsibility of a governing body, when the governing body is a volunteer board of directors, as in C, where that responsibility is can be delegated to an executive and an executive team. So it just seems to be a contradiction there between C and D.
Thank you. Thank you so much for those thoughtful comments, Barbara. And I really appreciate that you did your homework in advance, coming to with specific points to discuss. I will say thank you for that. I think that you know, in D, I've got that pulled up on my screen now. Of course, governing body, if it's the case that that governing body just is the executive management team, that would be covered. But what I'm hearing is we probably need some language similar to C, where saying if we're a both and organization, we've got the board of directors and the executive management team, we need to include that similar language in D. So appreciate that. I think we can definitely, I mean, I think that is our intention. We can include that. And also thank you for your comments regarding that. The reviewing changes, we'll definitely take that into consideration as well. So appreciate that, Barbara.
Thank you.
Thanks. All right. 2.6, personnel and contracted services. So this includes oversight position requirements, background check requirements, including written criteria for evaluation, of which convictions make a candidate ineligible for hire, personnel records, as well as personnel training. And this one I will pass on over to Mel to address this new section on clinical supervision, which is our reworking of the infamous 50% staffing ratio rule. Mel.
Thank you, Victoria. Hello, everybody. So yes, as Victoria said, this section is new and it was inspired by all of the feedback that we received regarding the former 50% rule for staffing requirements found in the service chapters, specifically in speaking that there needed to be 50% licensed staff to 50% candidate staff at an agency. So what we have done is from that stakeholder feedback, we are removing the 50% rule, woohoo! And we have created this new clinical supervision area in 2.6.1. So clinical supervision section here, we have worked with our state partners through HCPF and also through DORA to ensure that we're not overstepping any bounds. From our standpoint of clinical supervision, these things are things in clinical supervision that should already be happening at agencies. And this is specifically for clinical supervision at the agency level and not clinical supervision at the individual level. So what we have here is that BHA must provide clinical supervision to all personnel providing behavioral health services. Now there is an exception, and that is specifically for peer support professionals, and their supervision language is found in Chapter 6, which we will discuss that in a future town hall. The BHA will develop policies and procedures for clinical supervision. And this includes things like ensuring the mandatory disclosure statement clearly states the supervisee is under supervision and by whom, frequency of documentation reviews with feedback from the supervisor, and maximum number of supervisees a supervisor oversees at that BHA. There are also minimum standards for personnel providing clinical supervision for a BHA. Woo, I get that BHA language messed up too already. So again, these are not anything that should not already be happening by a clinical supervisor. And this includes things like meeting standard qualifications for a clinical supervisor defined by their professional practice board, and delivering clinical supervision within that professional practice license and ethical standards for either those that are licensed or seeking licensure, or for those that when supervising personnel not seeking or not eligible for licensure, that supervision is happening within the Colorado Mental Health Practice Act of that 12245 standards. We also have language included for personnel specific requirements. And these include things like licensee. Now, again, this is formerly that licensed mental health professional. Now licensee is anybody who has an individual license through DORA providing clinical services. That the BHA must make supervision or consultation available upon request from the licensee or at a time of emergency. That candidates receive supervision either at a rate that is in compliance with the DORA standards for that licensure requirements that they're going for, or at a minimum of 1 hour every 2 weeks, whichever provides more supervision takes precedence. And then we also have something written in for personnel not seeking or not eligible for licensure, but they're still providing clinical services at that BHE. So these can, again, include things like group living workers, that they are provided supervision at a frequency that ensures treatment is appropriate and safe while matching that individual assessed need and treatment goals. Okay, and I will hand it back over to Victoria.
Before we do that, Barbara, did you have a question on this clinical supervision?
Yeah, Mel, I'm sorry, I didn't hear what you said about number 4 when you gave the example. You said, for example.
Oh, I'm sorry. That may have been a couple of examples for the policy and procedure, or I spoke about a couple examples of things that a clinical supervisor must do.
I'll be more specific then, because when you said personnel not seeking or not eligible for a licensure, and then you said, for example. So I guess my question is, does this number 4, does that mean, let's say, a bachelor's level individual who under HCPF codes is allowed to provide certain services? Is that what is meant by in D4?
That is correct. That is absolutely that person. We worked with HCPF to make sure that that language was covered within this clinical supervision area and within the clinical supervision definition that was Mariana spoke with back in 1.3. So an example of that is a group living worker. Again, that bachelor's level folks.
Okay. And is it only those in residential, or is it someone, could it be someone who's not in residential?
It's across the board, anyone that is providing behavioral health services that is not seeking or not eligible for licensure, but that you're able to bill HCPF for those services.
Excellent. Thank you so much. Much appreciate that you added that. I know that everybody throughout the state is sending blessings your way.
Well, we are super excited about this new area too. So thank you very much for the feedback.
Right. Thank you.
Right. So moving on to part 2.7, general building and fire safety provisions. This is applicable to those with a brick and mortar location. So for any providers who are telehealth only or are only providing community-based services outside of a brick and mortar provider location, these requirements would not apply to those particular providers. This is for locations where individuals are receiving services. And includes compliance with local zoning, housing, fire, and sanitary codes, as well as compliance with life and safety code of the Colorado Department of Public Safety. And this certificate of compliance is statutorily required and will be required in the BHA application. Individual records, part 2.8. So this is record access for individuals and designated representatives, includes retention of records and a record for each individual that includes, as applicable, their demographic information, screenings, assessments, and service plans, advanced directives, their medication administration record, out-of-state offender questionnaire. I know some statutory changes have come about in terms of timing of that questionnaire. So just want to note that we are aware of that and making sure that our regulations are in conformance with the new statutory requirement. Personal belonging inventories in the case of a more overnight or residential service, court documents, communication with referral sources, such as court, probation, child welfare, and parole, and drug and alcohol testing results. Part 2.9 speaks to individual rights. So the policy regarding individual rights, which does include the right to participate in decisions involving treatment and giving informed consent, refusing any treatment, equitable care that recognizes an individual's dignity and cultural values, information about billing procedures, safety, including freedom from abuse and neglect and improper restraint or seclusion. And we'll go into more specifics on that restraint and seclusion, register complaints, and also their right to confidentiality. 2.10 speaks to dispute resolution, including a posted notice about the process to register disputes with the agency or submit grievances to the BHA. So a little bit of a nuance here is that dispute, when we say dispute, that is an agency internal complaint, whereas a grievance is a complaint that goes to the BHA. The process shall include resolution of the dispute within 30 days and that there is an internal representative, not part of the care team, that can assist in resolving those disputes. 2.11 is our part on individual services, so that services are provided in the least restrictive and most integrated appropriate setting. This is where regulations regarding telehealth and public community-based settings is found. So this includes audiovisual or audio only as allowable by service type and per state and federal regulations, policies and procedures for those telehealth services, as well as for those public community-based services, access to emergency services, providing information about how to access that 24/7, referral to those services if needed, and information regarding care coordination or assessing needs in navigating individuals to appropriate services and resources. We'll be diving more into care coordination services in chapters 3 and 4, but this is really being conceptualized as care navigation, so a very basic level of care coordination for individuals. I will pass this over to Jenna for screening and assessment.
Perfect. Hi, everyone again. I'm going to talk about screening and assessment as well as admission and discharge. So some of the things, we've made a couple updates in the screening and assessment area based off of previous stakeholder feedback, as well as working towards that parity between mental health and substance use. And so one of the things is personnel meeting qualifications under part 2.6.c can complete that screening unless there is identification of imminent risk. Then that must be reviewed by either a licensee, a LAC, a CAS, or a licensure candidate, but trying to allow for other individuals to be able to complete that screening, as I know originally it had said just by the licensee, LAC, CAS, or licensure. So we made some modifications there. And then also in the screening portion, we have moved the pregnancy and postpartum status screening for that up to the main screening portion instead of separating that out for SUD specific sub-endorsements. So working towards, again, that parity. Imminent risk evaluation, one of the asks was to include screening for withdrawal management. And so we have added that in. And then also there are additional screening, there might be additional screening requirements in specific endorsement chapters. So it may come up in a different chapter that they may have some additional certain timeframes and or other requirements that aren't in this general BHE license portion. Next slide, please. So then, as many of you may know, we incorporated this initial assessment to allow or to reduce administrative burden and lengthen the time for agencies to complete the comprehensive assessment. So it's getting some of those key pieces in for reimbursement portions, but also allowing for time for the individual and the provider to build trust and build and kind of have that time to be able to get some of that more information, that demographic information. And so we have included this initial assessment. We've also included the risk assessment in screening, initial assessment, and comprehensive assessment, making sure that there is constant assessing for imminent risk of the individual. And then that screening portion for pregnancy status and or that desire to become pregnant with the inclusion of screening for HIV, AIDS, TB, and hepatitis A, B, or C was removed from that screening and SUD specific endorsement down into this initial assessment. So not having to necessarily ask that on initial screening, but still requiring that information. And then again, as stated, timeline specific or timeline requirements are located in those endorsement chapters. So some might be 14 days, some might be a little less. So it's really dependent in those endorsements, which will be addressed later on in other town halls. Next slide, please. Thank you. Oh. And I will stop for you, Cindy, real quick.
Shoot, forgot to unmute myself. Thank you. So I very much appreciate the pieces around parity and trying to push for some of the more sensitive pieces. I am looking on the screening under the initial assessment. So, and I know it is based on what type of endorsement, but if we think about for outpatient, that initial assessment will need to be completed within 10 days is my understanding. And so would really, I'm wondering if there's anything we could do that screening for HIV, AIDS, TB, those infectious diseases, doing that within 10 days is not much time for relationship building. So if there's anything that we could really within this commit to, and I know we've got that language, but trauma informed. So really asking the fewest questions or the fewest amount of detail to be able to get to that. So I would just want to put that in that 10 days still is not much. And really what we see in practice is people shy away from this, and it does feel like a barrier to care. So anything that we could do, just a light touch here with further assessment and comprehensive would be helpful. The other thing is we talk about, if you look at 11A, it says individuals shall be screened for past or present risk factors associated with substance use disorders that are associated with pregnancy and then all of the infectious disease. And I would just say, I believe that there are mental health conditions that put people at these same risks. And so wonder if we might strike the associated with substance use disorders, that it is a more general screening for the populations that we serve.
Thank you so much, Cindy. I'll address a little bit on that moving of the screening for the HIV, AIDS, TB, and hepatitis A, B, and C. One of the reasons why we still kept it in the initial assessment versus the comprehensive assessment is the awareness that depending, obviously we hope that people stay in treatment for a longer period of time to reach that comprehensive assessment, but we're not there. I mean, unfortunately, not everyone stays in through that 60 days, especially in the 60-day requirement for comprehensive assessment. And so we wanted to make it a little less stressful by not having it in the initial screening, but we still wanted to make sure that that individual is receiving those services. I think it's something that we can still definitely continue this conversation of how do we make this less intrusive of, you know, screening for that, all of that information within the initial assessment, especially within that 10-day time frame. But we were discussing how do we make sure that information is still being gained and we're getting them those resources, especially knowing that not everyone makes it to the comprehensive assessment. They drop out of services for various reasons. And so we're still trying to balance that portion of how do we ensure they're receiving services in that timely manner, making sure that they feel comfortable, or obviously as comfortable as you can be with some of these questions. Obviously, there's still very intimate conversations to have around this. And so I think that's definitely something we can still continue to have, is how do we make sure we are addressing these questions and conversations while still ensuring that they're receiving this information with that knowledge that not everyone stays in treatment for that 60 days. And then for the other portion about the screening associated with substance use disorder, that is something I will definitely take back and make sure that there's no specific reason of why that language that was pulled directly from our current 2 CCR 502-1. And so I will take that back and look into that one a little bit further to ensure that there's no specific reason, but I completely agree for the parity's sake that we should be looking at all of those angles. So thank you.
Thank you, Jenna.
I would like to if we have a moment, if you don't mind me interrupting, Jenna, I apologize. There's a question in the chat from Sarah about will the FGI review be required for this application as well? We are currently considering removing the FGI review requirement from our rules. And so we definitely want to ask for your feedback on that, whether that feels appropriate or not. So just want to let you know that that is something that is on the table for discussion, is that FGI review, and would appreciate your input and thoughts on that. And with that, I'll go back to Jenna.
Yeah, thank you. And then I also see a question in the chat about the initial assessment, if there are specific credential requirements for staff completing. that one has, that one is specific to, or that one starts going into what's required from the comprehensive. So that one requires it being completed by that licensee, the licensed addiction counselor, certified addictions counselor, and or licensure candidate performing within their scope. So that one does have a little bit more specific requirements associated to it of who can complete the initial assessment. So it's not just any personnel defined in that 2.6.c as the screening is. So that one does have credentialed requirements associated. Alrighty. And then for the comprehensive assessment, again, we're trying to incorporate that mental health and SUD assessment criteria, making sure we're having that parity. And again, as I said earlier, addition of risk assessment for to all levels from screening, initial assessment, and comprehensive assessment. It used to only be during screening, and so trying to make sure that we are continually assessing for imminent risk. And then there was the addition of the mental status exam, and one of the parts within that, it was a comment it made in some of the previous stakeholder feedback, is making sure that when that mental status exam is being completed, that personnel are considering other diagnoses or disabilities that may impact that speech or motor activity, and so trying to incorporate more inclusivity. And then we are also and one of the things that we're trying to balance here is the knowledge that not everything has to be addressed in initial assessment as it does in the comprehensive. And so those can be those can be in tandem of, you can build on it. You don't have to have a separate initial assessment and then start a new comprehensive. That can be added per the as the timeline allows it. And so in it, we are still also assessing for that HIV, AIDS, TB, hepatitis A, B, or C, or other infectious diseases. So that has been also added into the comprehensive assessment. I know this kind of speaks a little bit to what you were talking about, Cindy, of how do we how do we make sure that that's not being intrusive in that initial assessment area. And so we have added it into the comprehensive. I realize that seems duplicative, but we're trying to make sure that individuals who are receiving care, receiving information about that, receiving services pertaining to any of those any of those portions out of the assessment that have been asked. And so we've had it added in two places. And again, I'm going to try to look in and see how we can make that as clear as possible and less intrusive. And then one of the things with the assessment is that it must be developmentally and age appropriate, as well as culturally responsive. And then per all the other parts, there may be additional requirements in any of the endorsements, depending on what is needed for a level of care. Next slide, please. And then I'm going to go into 2.13, that admission and discharge criteria and service planning. So there are policies and procedures around that admission and discharge criteria, what it looks like to transfer or refer an individual to another provider, the timely discharge of an individual upon request, discharge summary to ensure continuity of care, a service plan that is appropriate to the individual that describes that type, frequency, and duration of services, and that the individual is a part of the co-creation of the service plan and a copy is offered to them. So asking that all BHEs are creating policies and procedures around these portions, and it obviously details it in 2.13. And I will pass it on to Mel.
Great, thank you, Jenna. Hello again, everybody. I'm gonna pick up the pace here a little bit because I'm looking at our time, and we really want to make sure that we have plenty of time for questions. This section in particular is something that will also be addressed at a 2765 provider designated meeting on June 7th. And then we will also talk about this section because it repeats itself in chapter 15. I believe on June 21st, I will double check the date when I'm done with this slide and put it in the chat. So 2.14 is specific to protection from involuntary restraint or seclusion. Further details on when these interventions can and cannot be used is in this chapter, along with information about policies and procedures needed by the BHE. Now, this does include, if you are a BHE that you will not use restraint or seclusion, you need to have a policy and procedure that states that purpose. So make sure you read through this policy and procedure section, especially if you do not use restraint or seclusion, but still hold a BHE. We also have language around if the BHE is not 2765 designated, but they do implement restraint or seclusion, they must transfer the individual to a 2765 designated facility if after first hour of being in restraint or seclusion, it is determined by an authorized practitioner at the time of the evaluation that further seclusion or restraint is needed. So then they'll be transferred over to a 2765 designated facility. We have information included around increased personnel training and demonstration of knowledge and application of that training to ensure that we are upholding best practices of these two emergency intervention and also best safety applications for these restraint or seclusion practices. We've added standards of care at time of admission. We've also looked at the timelines for orders, and we've reduced those timelines to 4 hours, and we've increased the regulation for protecting and monitoring individuals while they are going through this event. And yes, thank you, Mariana, for putting that in there. I appreciate it. So the information about those future meetings, Mariana just dropped in the chat for y'all. We also have added requirements around documentation and ensuring that appropriate debriefing for the individuals is happening after this intervention event. And then we have looked at the federal regulations of 42 CFR 483, and we've added those in throughout this section, specifically for seclusion, restraint, and physical management of a minor. Next slide, please. We also have information in 2.15 around medication administration. Now, this is incorporated specifically from CDPHE rules around QMAP standards for the BHE requirements. And it also is that unless otherwise licensed to administer medications, so that is those folks that hold an RN, an MD, or an APRN, those personnel administering medication must be trained as a QMAP or qualified medication administration person. And I will hand it over to Victoria.
Thanks so much. And as Mel mentioned, we're got about half an hour left here, so I'm going to keep my presenting pretty succinct so that way we can hold time for questions. So 2.16 is our critical incident reporting section, includes language from the critical incident reporting policy manual. This includes the addition of statutorily defined occurrences that are required to be reported, and clarification about what counts as a critical incident and the time frame for reporting. That time frame specifically is within 1 business day after the occurrence or within 1 business day of when the BHE determines that a reportable occurrence has happened. 2.17 speaks to the quality management program, requires development of that quality management program that is reviewed and approved by the governing body. And the plan includes identifying quality management projects and the implementation of improvement strategies. Now we're getting into the nitty-gritty technical stuff as far as receiving a license. So this is the initial application procedure. Applications must be complete upon submission, will be considered abandoned if not completed within 12 months. It requires a fingerprint background check from owners and managers, and the application information includes things like professional liability insurance, organizing documents required by the Secretary of State, information regarding any adverse actions, civil judgments, or criminal convictions of owners or managers, the lease if applicable, and that certificate of compliance as mentioned earlier from CDPS. It also includes information about the fee schedule, which we'll go into on the next slide. So this fee schedule was adopted entirely from CDPHE's current fee schedule. I will note that note on the bottom that this fee schedule is being taken under consideration and alternatives are being considered as we have received some feedback on this fee schedule already. Just wanted to let you all know that that's something we are considering internally right now. That fee schedule is a base license fee of $1,750, an outpatient endorsement costing $700, regardless of number of locations or service endorsements. And then the residential overnight endorsement, because that is additional regulation that needs to be done, additional work that needs to be done on our side, that is $900 per physical location, regardless of the number of service endorsements. 2.19 includes the process for provisional licenses. So this is a situation where if an applicant is not in full compliance, but is making a substantial good faith effort to comply, upon an initial license application, a provisional license may be issued. This can be effective for 90 days and may be reissued once. And the BHA may review the agency during that provisional period and would issue a regular license if the applicant has achieved reasonable compliance. I just want to address, I think a number one question we hear around these provisional licenses is, how does that affect reimbursement? So for example, Medicaid does accept provisional licenses with full faith and credit as a full license. So having a provisional license should not be a barrier to reimbursement. 2.20 is our license renewal process. So that renewal application submitted at least 60 days prior to expiration. There's a late fee that could be assessed if that is not done in a timely manner. And then a renewal fee schedule that was adopted from CDPHE, and you will notice is a bit lower than those initial fees because there is less of that upfront work needing to be done on the BHA's side. 2.21 speaks to change of ownership and management, including submitting a letter of intent and an application for change of ownership. It includes the description of what is meant by change of ownership by agency type. It includes that the existing licensee, the existing BHE, is responsible for plans of action to correct rule violations before the change of ownership is effective. After that time, the new ownership is responsible, and includes information about the fee for change of ownership, which is equivalent to those initial license fees. 2.22 speaks to our rule waiver process. So agencies can apply to have a regulation waived. One important piece of that is that statutory requirements cannot be waived. So for example, that certificate of compliance is a statutory requirement and therefore could not be waived. Only regulations can be waived. The term of the waiver shall not exceed the current license term. To extend past the license term, a new waiver application would need to be submitted in advance. The BHA waiver committee reviews that request and either approves or denies it within 90 days. Terms or conditions may be imposed on a waiver, and waiver may be revoked under circumstances described in this part of the chapter. 2.23 speaks to continuing obligations in BHA oversight, including the requirement to maintain internet access and a valid email address. This section also speaks to the opportunity for tiered inspections, meaning that BHEs may be eligible for less frequent inspections under certain circumstances, like not having enforcement activity or any patterns of deficient practices. So less frequent or a smaller scope of inspection is what is meant by the tiered inspection approach that CDPHE currently uses, that we are carrying over or anticipating to carry over at this time. The BHA may conduct unscheduled inspections. BHEs are required to provide anything needed for regulatory oversight, including access to records and reports, and this includes the plan of action process to address rule violations whenever that is needed. 2.24 speaks to enforcement. including license denials, the process for that, that would be issued in writing and may occur for reasons including but not limited to non-compliance of these regulations, submitting false or fraudulent information, refusal of inspection, or failure to complete a plan of action. At the end of the day, our goal is to really make sure that we are assisting providers to come into compliance with these rules. And so those plans of action are really a tool with which we can do that, to come together and make sure that providers are in compliance. License revocation or suspension shall be for good cause and issued in writing for similar reasons as above. Non-compliance, submission of false information, refusal of inspection, failure to complete a plan of action, or undue influence or coercion over an individual. This includes summary suspension in cases where emergency action is needed to ensure health, safety, and welfare of individuals. This section also includes the provision that conditions may be imposed on a license if necessary. Intermediate restrictions may be imposed, which may include retaining a consultant, additional monitoring, training, complying with a plan of action, or paying a fine. And agencies have the right to due process over all of these enforcement actions and do have the right to appeal, which is an important piece to note that due process is really protected in the case of a licensed BHE. 2.25 speaks to BHE closure, so procedures for temporary, emergency, and permanent closures, record access and retention in that case, and ensuring the continuity of care for individuals served. And with that, I'll pass it over to Mariana, who, as promised, is going to bookend us. And looks like we're flying through. It looks like we should be able to make it through our content. And of course, have some time for questions. Go ahead.
Yes, I think we will comfortably be able to close the book here. So this last couple parts that we have to cover in chapter 2 are related to residential and overnight standards, and then we'll get into fentanyl and other opioid treatment services. So this particular slide, we do have a handful of standards that are added into chapter 2 that will be applicable across the board to all residential treatment settings. This will include overnight crisis settings such as ATU, CSU, and residential respite. And this particular section also includes some health safety requirements relevant to overnight settings, including environmental safety, infection control, food safety, and dietary services. This is not something that lives in our current rule volume, and we do need to make sure that we have some base standards that are appropriate across all type of residential services, and that's where this information lives for all residential settings. Next slide. Okay, so then this last part that we'll cover here, 2.27, is related to fentanyl education and treatment. So this particular section of rule is introduced to satisfy requirements of House Bill 22-1236. This is referred to as fentanyl and other opioid use disorder education and treatment. This particular expectation is required of all agencies that provide services for treatment of SUD services or substance use disorder treatment services, including fentanyl and other opioid use disorders. So I'm going to go ahead and pop into the chat here. We do have the definition of fentanyl education here, and the education component has already been developed and is publicly facing. So you should be able to access that in the chat. And essentially the way that this will work and how we have envisioned it, and we're certainly open to feedback, is the referral for this individual to receive this particular placement will be received by the criminal justice entity. This is 100% based off of legal charges that they have received or involvement that they have with fentanyl and other opioid use. The agency will verify and document completion of their court-ordered education program prior to discharge from treatment. This is a little bit different than how we conceptualized it at first. We received feedback that we want to make sure that the individual is able to properly receive and understand the education component, and having a particular timeline on that prior to admission or at admission, or potentially even 2 weeks within admission, may not necessarily capture everything that the individual needs, or may not match everybody's best way of learning and being prepared for this information. So prior to treatment discharge, this needs to be completed and verified. Next slide, please. And what we wrote in is really trying to focus on development of support systems and making sure that medication for opioid use disorder services are available to that individual, whether through the agency and direct service provision or with active collaboration with other agencies that are capable of providing those MOUD services. There's an emphasis in this particular section of rule to focus on opioid antagonists and making sure that that is available on site at all times, and that these can be made available to individuals receiving treatment to keep on their person at the time of the initial assessment. So this can be provided either directly or through coordination with another resource. And I know we have a handful of questions that we've received about what would that look like and funding and items related to that. So that is something that we're continuing to look into, but our hope is to spread the expectation and support as far as making sure that this is the base understanding, that it is available, and that we're spreading the word of how to make that happen. There's a focus on all individuals receiving treatment know how to administer an opioid antagonist in case of an emergency or overdose, and that there is a promotion or directly providing this information to individual support system. Next slide. And for this particular section, we wrote in some standards around that all personnel must be trained to use the opioid antagonist and recognize symptoms of drug overdose. And this is again intended to spread education and potentially save lives. And then personnel providing the actual treatment and peer support professionals providing some of those support services are trained and demonstrate competency in these following training categories. These were developed in conjunction with our state opioid treatment authority of how can we take this expectation and really capitalize on making it helpful for providers and for individuals receiving this service, and what potential gaps do we have in place around these trainings. And these were some of the areas that we targeted for making sure that there's more information out there. Substances of misuse and dependence, pharmacology of medications for opioid use disorder, cultural competency related to current misuse trends for opioid involved individuals, and harm reduction and trauma-informed practices in the treatment of opioid use. Next slide. And then again, with this being a legally initiated level of care or service that needs to be completed in order for the individual to satisfy a condition of probation, the standards that we set in our current rule are that the agency shall communicate regularly with the referring criminal justice entity. Of course, with written permission from the individual, we need to make sure that's part of the process. But the communication is required for that period of time where fentanyl and other opioid use specific services are clinically necessary. This clinical necessity can be determined by, I see licensed mental health professional. I think that's one that we should have updated. That would be licensee. That would include the licensed addiction counselor as well. So that is an error on my part. Sorry for the inconvenience there. Candidates or certified addiction specialists as they are trained and able to determine when that clinical necessity would end for that particular individual. And then beyond that point, the communication with the criminal justice entity becomes optional once that opioid specific clinical necessity is no longer necessary and the condition of probation no longer applies. We certainly will encourage that treatment team approach as well, but also want to recognize that that will be the individual's decision, and we want to support the next step that they would like to go with it. And again, the last point emphasizes that this does require written permission from the individual, as we do need to follow with all court-ordered treatment. Next slide. Okay, and I know I saw a chat. I didn't get a chance. Let's see. Okay, so Sarah's question. So is this only required if a referral from the criminal justice system comes to a treatment center, not just required for any treatment center treating opioid use disorder? That's a good question, Sarah. Hopefully, if I'm understanding it correctly. We have yet to see what this is truly going to look like as far as scope and what these referrals are going to, how these are going to shake out once this starts really coming into play. So part of the reason that we set this into the base standard of Chapter 2 is a lot of this treatment really does fall within the scope of practice of addiction professionals. And so we really want to lean into practices that are already in place, and knowing that licensees and addiction-focused professionals already can provide and do provide this service. This seemed like the best place to to add this extra expectation because it's not necessarily adding much more as far as requirements for that individual practitioner as well as for the agency. So I think if I'm understanding that question correctly, it's really, if they come over with the referral, that is where the condition of probation and that communication with criminal justice would kick off. It is based off of that particular legal requirement. And I'm looking at you, Mel, in case I'm not answering this question accurately, but we do have it set up that this would be applicable to all substance use involved agencies, again, because they can and do have this practice within their scope of practice of their practitioners. Anything you would add or clarify there, Mel? That was a little rambly.
No, I think Mariana, I think you said it very well. This was something that in working with the state opioid treatment authority and developing the section as well, we wanted to kind of zoom out from just, oh, well, it's criminal justice services, because these folks can walk in the door at any of the base level agencies, and we want to make sure that they're receiving the appropriate services at any level. So that's why we plugged it into the base BHA.
Any other thoughts, questions, or concerns on that? Book closed. Back to Victoria.
I was going to say, as you may have noticed, we've concluded our presentation. We made it through all of our prepared presentation, and so now we're happy. We've got about 9 minutes left. If there were any questions that you would like to ask, any feedback you'd like to provide on the rules, I will also take a moment now to plug the stakeholder event calendar on our webpage. We have a number of additional events if you want to let the content today kind of sink in and do a little more reading of the regulations and then join us at a different meeting to provide feedback. That is very welcome. We will be going around the state to 7 different cities. Please register in advance for those in-person stakeholder opportunities to make sure we know we're going to be meeting some folks when we go out into the community. And with that, I will pause now to see if there were any other questions or comments anyone would like to provide. Thank you for that question, Edie. Edie asked in the chat to confirm the deadline for input, June 23rd. That is correct. So we will continue to have meetings up to June 23rd, and we will be receiving input at those meetings, and then written input will shut off at midnight on June 23rd. I think we had a question before when we had a deadline of, is this by close of business? Is this by midnight? In case anyone really gets excited going up to the wire and wants to provide that feedback at 11 p.m. We will keep our comments open until midnight on June 23rd. So we've got about a month and another week for that. And then just by way of expanding on that, this team that you see today will be taking a week. We've blocked off our calendars. We are going to deep dive into all of this feedback and integrate it into the rule volume as appropriate. We will be doing that throughout this 2-month period, but really focused on getting a final product ready in that last week of June, so that we can get the rules to our attorneys for legal review on July 1st. I'll give it another few seconds in case anyone is typing. All right, well, with that, thank you all so much for joining us today. We will have these slides available as well as the recording available on our web page. You all came with some excellent questions and we're very engaged. We really appreciate that. I think that we had some very helpful conversation today. We received some important feedback that we are taking under consideration. And with that, I think we can wrap